We will move on to next session. I would like to invite the chair, Dr. L. Venkatakrishnan, Department of Gastroenterology, PSG Coimbatore, Dr. Kinshuk Das, Senior Consultant, Apollo, Kolkata, Dr. Harshavardhan Rao, MS Ramaya Hospitals, Bangalore.
May I invite Dr. Mathew Philip, Director, Lissy Institute of Gastroenterology, Kochi, for his talk on autoimmune pancreatitis.
Thank you, the organizers, IPC, as well as CMC team, Sudipta, Ruben, for giving me this opportunity. Thank you, chairpersons. This is a story of a 68-year-old male who was referred to me for evaluation of a pancreatic head mass and FNAC. He was an alcoholic, a smoker. He has got mild jaundice of 3 weeks duration with minimal weight loss. Bilirubin was mildly elevated, alkaline phosphatase and gamma GT were elevated. CA99 was 124, is mildly elevated. CT scan showed a mass in the head of pancreas. EOS was done, which showed a mass in the pancreatic head around 3 centimeters, and there was focal thickening of the common bile duct. So we did an IgG4, which is awaited, and this is a CT scan, which you can see the mass there. Pancreatic duct is not dilated, and the whole pancreas, rest of the pancreas is not also atrophic. There are no major lymph nodes. And this is the EUS. You can see grossly thickened bile duct, mass in the head of pancreas. That will straight away give us a diagnosis that probably we are dealing with something called autoimmune pancreatitis. Because we have got dual lesions, and by definition it is a distinct form of pancreatitis characterized by specific features like obstructive jaundice with a mass in the pancreas, either focal or a diffuse one, and has got lymphoplasmacytic infiltrate and fibrosis, and has a dramatic response to steroids. When you look at the epidemiology, the studies have shown that it's being more frequently reported, probably because of the more frequent detection, but still, for me, it remains to be a rare condition. Either we are not picking up, or I think, in spite of working up all patients with pancreatic head mass, I still think it is not that common. When you look at the different types of autoimmune pancreatitis, I'm supposed to give only on type 1 autoimmune pancreatitis, but you know that the syndrome can be divided into multiple, and last DNA examination there was a question on type 3 autoimmune pancreatitis. What is looking at the etiopathogenesis? We know that there are different types of different pathogenesis, but in the classical type 1A, it is IgG4 related disease. This can either occur as an isolated disorder involving the pancreas predominantly or only the pancreas, or it can be a part of IgG4 related disease involving multiple organs. Generally we call it as other organ involvement. The clinical features, predominantly it is a painless jaundice in an elderly person, and that is the commonest one, and some patients will have abdominal pain, not very severe as that of a CF pancreas. Then they can have extra pancreatic lesions also. Weight loss is not that common, but can occur. Pancreatitis, acute pancreatitis, is extremely rare in this group of people, and it's more common in males. And these are sites of extraintestinal or extra pancreatic sites, rather generally we call it as other organ involvement, OOI. And looking at the diagnosis, not serological markers, we know that IgG4 is the hallmark for making a diagnosis for type 1 autoimmune pancreatitis, and it constitutes around 5 to 6% of the total serum IgG in healthy subjects, and the normal value is less than 140. If you have got a value of more than 2 times, that is around 280, it is highly suggestive of autoimmune pancreatitis. And it has a meta-analysis has shown that probably the sensitivity and specificity for this high value is quite high, but when the value comes down to between 140 to 280, it's actually not, we may have to call it as probability only that. So this can also increase in many other conditions. Less than 2 mg can occur in many other, even in pancreatic cancer it can get elevated. Skin disease can, asthma, or even parasitic diseases, skin lesions, etc. can elevate this. So we have to be very careful in interpreting these results. There are other antibodies which have been tried, but it is not found to be of any, other biomarkers are not found to be much useful. When you come to the imaging modalities, we know that the most common, ultrasound is not a very important modality in this patient, but generally we go for CT or MRI. There are classical features which can occur, and I will come to it later. And MRCP can sometimes tell you about the ductal changes, and very rarely only you do PET scan. This is basically to find out other lesions, not in the pancreas. And many times pancreas lesions by PET scan will not give you a clue between differentiating between pancreatic adenocarcinoma and this inflammatory mass, but both will get light up. US is very potentially useful, but not only for studying that, but also looking for the peripheral structures, the structures around the pancreas, the bile duct, etc. And this is actually the classical one which shows that here this is the uniformly enlarged pancreas, and you can see the capsule partially lit up, and that is the halo sign, and this is a bulky pancreas in the MRI, and the tail cutoff sign, this is tail basically quite bulky in that, and this is again, which shows that the peripheral enhancement or the halo sign. And this is one of our patients which actually shows that there is a lesion in the head of pancreas, and the gland as such is preserved well. When you look at the MRCP or ERCP for ductal changes, you can have variable ductal changes. But generally, the duct is not dilated. Generally, it's not dilated. But you can have strictures, and very rarely in a focal mass or inflamed mass, sometimes the duct can be mildly dilated on that. So the changes can be subtle, or it can be so obvious. It can be a narrow duct, focal, or multiple focal areas. Coming to endoscopy, why do you need endoscopy in these patients? Basically, we do an endoscopic ultrasound in this patient, either a conventional endoscopic ultrasound where you use all these techniques. We use a contrast EUS, sometimes you do elastography. This is all basically to differentiate between pancreatic ductal adenocarcinoma and an inflammatory mass like autoimmune pancreatic mass. You can do an EUS FNB, or in very few situations, if you really want to do a relief of obstructive jaundice, in those patients we can do a biliary stenting as well. When you look at the conventional EUS, there are variable signs which have been put into a cross. I'm not going to in detail, but there are certain things which can actually differentiate between pancreatic adenocarcinoma versus that of autoimmune pancreatitis. But you can also do ancillary techniques like contrast enhanced EUS, where you can see that in autoimmune pancreatitis mass, it can be a hyper-ISO enhancement, but in pancreatic ductal adenocarcinoma, which is ISO-hypo enhancement. And also elastography can also differentiate partly. In autoimmune pancreatitis mass, you get a homogeneous pattern, but in pancreatic adenocarcinoma, you get a focal heterogeneous pattern. But you can do an EUS FNB to differentiate, but it is not that wonderful in all the cases because the tissue may not be adequate to make a diagnosis on that. This is exactly an EUS which actually shows a mass which is a little heterogeneous there, and you can see the duct going through the mass, which is very unusual for pancreatic ductal adenocarcinoma. That is a duct penetrating sign which is already discussed by the radiologist in the talk. And also you can see other findings. You can see in this case there's a bile duct which, similarly what I have shown, the bile duct wall is significantly thickened. And when you do a contrast EUS, you can see that in this there is a uniform ISO enhancement of the lesion, which is not that common with pancreatic adenocarcinoma. It takes a little more time. It appears to be less enhancement, but it takes a little more time for getting enhanced on that. But I think that the hallmark of diagnosis is by the histopathology, and in the histopathology you get the cellular infiltration, cellular infiltration, you can see the periductal cellular inflammation, basically the chronic inflammatory cells, the plasma cells infiltration, as well as storiform fibrosis, so classical. This is best seen only in core biopsy or resection specimens, and also on changes on the SNR, and the classical is staining for IgG4 cells. When you look at the histopathology, you classify the level 1 or level 2, and in autoimmune pancreatitis type 1, if there are 3 findings, at least 3 findings, we call this a level 1, and if there are 2 findings, we call this a level 2. That is on international consensus diagnostic criteria, say ICDC. What is the role of ambulatory biopsy? Many times we used to tell that take an ambulatory biopsy. It all just depends upon the amount of plasma cells available or depositing in the tissues. I have not found this ambulatory biopsy any benefit, and generally people think it is not of much benefit on that. So how do you make a diagnostic criteria for autoimmune pancreatitis? There are different types. The ISOT criteria, I'm not going to the detail of it. Then came the Japanese Society criteria, but the most accepted is the ICDC criteria, where you have got a level 1, level 2, and you look at the histology of the pancreas, which I already discussed, parenchymal imaging, which we discussed already, ductal imaging, we discussed, serology, we already know about that. Then other organ involvement. That is actually very important. If you have more than one organ involvement, it is likely that we are actually making a diagnosis of autoimmune pancreatitis. And of course, the most important one is the response to therapy like corticosteroids. When you really suspect a person having autoimmune pancreatitis, a painless jaundice pancreatic mass, diffusely enlarged pancreas under imaging, pancreatic mass with the absence of pancreatic ductal dilatation, and absence of vascular involvement. Please note that when you do an EUS in a patient with autoimmune pancreatitis, you can see vascular lesions, but not a vascular invasion. You can see venous thrombosis, we can see arterial lesions, arterial thickening, etc. Vasculates, etc. can be seen on this because they're part of IgG4 disease. And also on other involvement, like retroperitoneal involvement and biliary involvement, other organ involvement is also very. And always when you get an isolated pancreatic mass lesion, in an elderly person where autoimmune pancreatitis is also common, the biggest challenge is rule out pancreatic ductal adenocarcinoma. So what are differential diagnoses when you got a diffuse pancreatic enlargement? This is lymphoma is one possibility, or is as a resolving acute pancreatitis. Many times recently one patient is referred to me by a sausage-shaped pancreas. Actually it was a resolving acute pancreatitis. And then of course the most important is pancreatic carcinoma, ductal carcinoma. Duct cutoff sign, pancreatic atrophy distal to the mass lesion or ductal obstruction, these are all very important on that. How do you manage? Before that you need to ask a few questions. Who should be treated? What is the best induction regime for, what is the best indication regime for giving a steroid treatment alone? Or when to taper, when to stop? Who needs maintenance treatment? How to treat relapsing patients? And when to do stenting. There are 3 phases of management. One is the induction of remission, maintenance of remission, treatment of relapse. And if you have different drugs, corticosteroid, or rarely in patients who are not responding, rituximab can be used for induction. Maintenance of reception is by immunosuppressive agents like azathioprine and MMF. And treatment of relapse, not responding to steroids at least twice, then we consider rituximab, or people use high dose of reinduction with steroids. The indications of treatment, as I told, symptomatic patients, all symptomatic patients needs to be treated. Asymptomatic patients, we found a persistent pancreatic mass on imaging or other organ involvement, all those patients should be treated on that. Corticosteroid is the first line of management, and it has been started on a dose of 40 milligram for an adult usually, that is 0.5 to 1 milligram per kilogram per day, and then gradually reduced over a period of 2 to 4 weeks, usually generally given 4 weeks, and then continued on a reduced dose for up to nearly 3 months. And suppose a patient is not tolerant or patient has contraindication for steroids, then rituximab can be used, and it has to be used very carefully. I have never used it for this purpose. Then steroid refractory cases, you can actually try a reinduction for mini pulse treatment with steroids again. If not possible, then rituximab. Maintenance therapy is with MMF and azathioprine, and many other drugs are being tried, but I don't generally think that people use all these drugs on this. Is biliary drainage needed? Not for all patients. Just because they have got biliary obstruction, don't try to put stent. But it can actually prevent infections when you start on steroids, and also you can take brushing and cytology for rural malignancy, but in some patients, we can just manage with steroids, the biliary obstruction comes down. Never think that surgery is not necessary, but when you are in doubt with pancreatic ductal adenocarcinoma, multiple attempts, it's negative or steroid does not work, I think, think about surgery in this patient. There are many new emerging therapies which I am not going to in detail. Response to treatment. I think majority will respond to treatment. And response not only clinically, but also you have to look at imaging and then make sure that there is response of. This is one of our patient which I have shown you. This is before treatment and this is after treatment. And what are the long-term complications? They can get pancreatic exocrine endocrine functions and the loss of parenchymal oleum. And many times the ductal become normal, but the parenchymal oleum comes down. What are the future directions? We need a better research on etiopathogenesis and also non-invasive biomarkers and exploration of novel medical therapies. And we know that artificial intelligence, the next talk is on that, is coming up in a big way. It's basically to find differentiate between autoimmune pancreatitis versus pancreatic adenocarcinoma. And I'm not going to the details of the algorithm, and this is my take-home messages. AIP may mimic pancreatic cancer, so this has to be excluded. Strongly relies on radiological and US imaging, and not only by histopathology. US is a valuable tool, but it is not necessary that you get adequate tissue on that. Medical management is actually induction of remission, management of relapse, and maintenance of remission. Corticosteroid is the mainstay of treatment. Rituximab is selectively used in certain patients. And early effective treatment can reduce the long-term complications of this. Thank you so much for patient hearing. I request all of you to join for the ISA conference at Amritsar. What you have not learned in IPC on pancreas, you can learn from there. Thank you so much.
Thank you, sir. Thank you for the necessary talk. My one question is, what are the relapse rates in these patients? And do we need to put them always on, who are the subset of patients who would recommend a maintenance treatment?
I have shown a slide on that because of the time I did not. Actually, in those patients who have got other organ involvement, or patient has got proximal biliary system involvement, or very young patients, and all these patients are high risk of having relapse. And almost as that 30% can have relapse on that. So many people actually put patients on steroids and reduce and put on 5 milligram, 2.5 milligram over many months or years. But generally, to me, if you ask me what's my experience, is the disease as such is uncommon, but we have only around 8 cases till now in last 5 years. And in all those patients, actually, we have started on steroids and 3 months we have stopped. But 2 patients came with relapse, and those patients we restarted on steroids and they are on azathioprine.